Hello and welcome. On behalf of CME Outfitters, I'd like to welcome and thank you for joining us for Unraveling the Neuroinflammatory Pathway and Disease-Modifying Targets in Alzheimer's Disease. The CMEO Snack Series is supported by an educational grant from Novo Nordisk. I'm Dr. Ali Zayatri. I'm a cognitive neurologist. I'm the Chief Medical Officer for Banner Research in Arizona, and it is my pleasure to welcome my distinguished colleague, Dr. Paul Edison. Paul, would you introduce yourself, please?
Thank you very much. I'm Paul Edison. I'm the Professor of Neuroscience at Imperial College London, and I lead the Imperial College Memory Research Center. I'm also Honorary Professor at Cardiff. So I've been working primarily on neuroinflammation in Alzheimer's disease and leading both clinical and research activities at Imperial. Thank you.
Great, and very, very happy to have Dr. Edison with us as a world expert on this topic. So as part of this activity, we also have interactive animation components. Additionally, throughout this CMEO snack, you will see parts of these animated components and where it fits into our discussion. All right, to frame the discussion today, let me first review our learning objective. Our goal is that for this CME snack, that you can evaluate the broad role of neuroinflammation in the pathology and progression of neurodegeneration, Alzheimer's disease, and the clinical syndromes of MCI going to AD dementia. All right, so we're going to start. Dr. Edison, my first question to you is, can you begin by discussing the role of a healthy inflammatory system and neuroimmune system? What does this consist of, and how has our thinking changed over the years? And how could it contribute to the biopathology of AD?
Thank you very much, Dr. Atri. So I think one of the things which is very clear is we have got these microglia in the brain right from the birth. So that the purpose of the microglia is to protect the brain. So what happens over a period of time? So if you were to look at what the glia is doing, it is surveying the brain and it is trying to protect. So we have the resting microglia. These microglia have got the ramified process, and when the brain is in the surveil, or when the microglia is surveying the brain, these ramified processes are in constant activation, and they sort of detect any changes happening in the brain. And when there is a damage, or in the Alzheimer's disease case, where there is accumulation of amyloid protein, you can see these microglia transforms its shape with a view to actually phagocytose the toxic products. And these microglial transformation can actually happen within 48 hours or 24 to 48 hours time.
Amyloid beta, particularly soluble monomer in oligomer forms, exerts toxic effects that lead to neuronal damage and loss. Amyloid beta initially exists as monomers, which can aggregate into oligomers. These oligomers then further assemble into protofibrils, which are intermediate structures. Finally, protofibrils undergo additional structural changes and aggregation to form mature fibrils, which are the main components of amyloid plaques found in the brains of individuals with Alzheimer's disease. Evidence suggests that normal actions of sodium-potassium ATPase pumps, alpha-2A autoreceptors, activation of GSK3 beta, and other processes, can be adversely impacted by amyloid beta. Additionally, excessive and chronic immune system activation can be both an initiator of and response to the presence of amyloid beta pathology in the brain.
Now, if you were to actually look at what happens in the disease stage, these microglia, which are predominantly coming from the brain, and a small percentage which can come from the periphery, they get activated And once these microglia gets activated and the initial purpose of protective function of the brain becomes overwhelmed, and then there is damaging effect of the microglia sets in. So this damaging microglia can secrete several pro-inflammatory cytokines, and these pro-inflammatory cytokines can actually lead on to significant neuronal damage. When there is a toxic insult, particularly in the form of deposition of amyloid in case of Alzheimer's disease, and other toxic protein accumulates, these microglia gets activated. And the activation of these microglia leads on to neuronal damage. However, there are several processes happens in between. They secrete the toxic proteins, and these toxic proteins also causes a vicious cycle of neuroinflammation and neurodegeneration. These toxic proteins also can cause increased blood-brain barrier permeability, which leads on to increased infiltration of the peripheral inflammatory cells. This vicious cycle can carry on unless we can intervene by some treatment or clearing the toxic insult.
In cerebral amyloid angiopathy, CAA, amyloid beta 40, depicted here in green, is deposited into walls of cerebral blood vessels. 80% of patients with Alzheimer's disease have evidence of CAA pathology. These deposits lead to replacement of smooth muscle cells by amyloid and increased blood-brain barrier permeability. Disruptions in barrier integrity allow the infiltration of immune cells from peripheral inflammation into the brain parenchyma.
And there are several factors which could actually influence the glial activation, and in a sense that mediates quite a lot of toxic proteins in the brain. So if you were to look at the risk factors, like cardiovascular risk, insulin resistance, diabetes, obesity, then the ApoE4 genes, presenilin mutation, and any other predisposing features for Alzheimer's disease can actually impact the brain through inflammation. Even though we knew the inflammation is an important factor, so far we have been focusing primarily on amyloid and lately on tau, but what we are seeing is inflammation plays a significant role in the neurodegenerative process. Now, other important factor for inflammation is the systemic inflammation, where you can see not only the chronic inflammation like the diabetes, obesity, acute inflammation can also cause neuronal damage over a period of time. If you were to look at actually induce inflammation by giving LPS, you can actually see the brain inflammation going up by PET scan. So this is very clearly demonstrated. So it shows that the systemic inflammation can influence the central inflammation even in humans. And it is a real challenge actually to prevent the systemic inflammation, because over a period of years, we accumulate these toxic proteins and these toxic insults. And this is a significant challenge. But in the case of diabetes and obesity, treatment of these conditions can have a significant impact.
Optimal levels of inflammatory mediators in the bloodstream help to regulate immune responses in the brain. Peripheral inflammation and hyperglycemia can compromise the integrity of the blood-brain barrier. Infiltrating immune cells can trigger microglial activation and astrocyte reactivity, leading to neuronal damage and cognitive impairment. When inflammatory cytokines bind to this neuron, downstream phosphorylation inhibits insulin signaling at its receptor. Unlike in peripheral tissues, insulin in the brain does not control glucose uptake. Instead, it modulates many neuronal processes. Inhibited insulin signaling results in increased activity of GSK3 beta and tau phosphorylation.
Thank you, Dr. Edison. So yeah, so very clearly link between chronic systemic inflammation, these metabolic syndromes, and both contributing or exacerbating, proteinopathies that are already occurring in the brain. All right, Dr. Edison, you already started the the link between neuroinflammation and AD pathobiology. What would you say is our current understanding or models of AD pathobiology, everything from amyloid accumulation to tangles and impacts on neuroinflammation, how this works into it, vascular components, mitochondria, lysosomes, and so on and so forth.
Yeah, so the inflammation is actually a vital part of the pathogenesis of Alzheimer's disease. And so if you were to look at what happens in the amyloid deposition, so we have got the APP being cleaved by the beta secretase, and then that it causes the amyloid aggregation. Now, these amyloid aggregation actually induces microglial activation. So the first response of this amyloid as a toxic protein is the microglia wants to clear the amyloid. So these microglia, the so-called anti-inflammatory phenotype of microglia gets activated. So the idea of these anti-inflammatory microglia is to clear these amyloids. What happens in real life is these anti-inflammatory phenotypes of microglia either become dysfunctional or become overwhelmed by the aggregation of the amyloid protein. See, these amyloid protein then causes overactivation of the microglia. And either these anti-inflammatory microglia can switch to pro-inflammatory microglia, or indeed there could be other pro-inflammatory microglial activation. Once these pro-inflammatory microglial activation happens, that can secrete several toxic proteins. So one of them is IFIT-M3, and then there is a secretion of zinc, and it also causes increased aggregation of A-beta. Now, on the other hand, it can also secrete IL-1 beta, TNF alpha, and reactive oxygen species. And those things actually causes activation of kinases. And these kinases can actually phosphorylate tau. So that can cause the tau hyperphosphorylation, and which lead to tau nanomers as well as oligomers. And then it can then lead on to tau tangle formation. And once the tau tangles are formed, these tangles are exogenous to, or they're not supposed to be in the brain. Hence, these tau tangles actually causes a vicious microglial activation. And then you can have a vicious loop of tangle formation, microglial activation, and again, that spreads in a vicious manner. Similarly, the amyloid also spreads in a vicious manner. So if you have to actually intervene, you need to intervene this vicious cycle, and then either by the drugs or by clearing these toxic products.
In a recent study, amyloid beta was associated with the development of dysregulated tau phosphorylation by kinases, such as GSK3 beta, but only in individuals who were positive for astrocyte reactivity. Astrocyte reactivity is associated with disruption of synaptic function and exacerbation of neuroinflammation. There is progressive tau accumulation in neighboring cells, promoting the release of reactive oxygen species and contributing to the progression of neuronal death. This vicious cycle of toxicity, perpetuated by neuroinflammation and effects of amyloid beta and phosphorylated tau, continues from mild cognitive impairment, MCI, to progress to notable cortical volume loss in Alzheimer's dementia. These processes may occur over a period of years.
So these microglia can actually cause damage to several of the biological systems in the brain. So if you were to look at what happens in Alzheimer's disease, you've got the triggered by the amyloid that causes mitochondrial damage. Inflammation causes mitochondrial damage. It can also causes damage at the lysosome, and several other pathways also activated. Now, some of the things which we were very much interested is to actually how to image microglia. This is one of the important aspects to understand the microglial pathology in Alzheimer's disease and other neurodegenerative disease. What happens in Alzheimer's disease and other neurodegenerative diseases is when the microglia gets activated, or if there is an insult, the microglial response is to secrete excessive translocated protein. These translocated protein, which are present in the mitochondria, we are able to image these by TSP or PET. It has got its own limitations. However, what we are able to demonstrate is that there is increased inflammation in the brain in people with Alzheimer's disease.
So this is a really great segue, Dr. Edison, to the new Alzheimer's Association revised criteria that were proposed, and they're not published yet, but they're, I think, getting close. That talk about the core biomarkers of amyloid and tau, and then sort of what we call ATN framework. Now that now it's the ATXN framework. So we have the core biomarkers like amyloid and tau, and we have proposed fluid and imaging biomarkers for those. But then this other category of biomarkers that are that are not core biomarkers of AD, but are involved in the pathobiology, the N for neurodegeneration and neurodisruption, things like NFL, for example, or imaging biomarkers of MRI atrophy and let's say hypometabolism on FDG PET, but also a category for eye. Well, for the first time, for inflammation. And then, of course, there's another category of the co-pathology that oftentimes goes along with AD, which is vascular brain injury and synucleinopathies. And I'd imagine in the future there'll be other proteinopathies added to that. So under that category of eye, for biomarkers, you already started talking about a imaging biomarker for eye inflammation. What other biofluids and other things do you see are getting close? And obviously, what's for research? Are we getting anywhere close to clinical practice with some of these other biomarkers?
So yes, I mean, I think the imaging biomarker, particularly from the inflammation point of view, it has got its own challenges. The first thing is whether we are able to differentiate between the pro-inflammatory and anti-inflammatory phenotype of microglia. So far, we are unable to differentiate between the pro-inflammatory and anti-inflammatory phenotype of microglia, which is a significant challenge in itself. But if you were to look at the fluid biomarkers, some of the fluid biomarkers are the GFAP, which is the gliofibrillary acidic protein, which is marker of astrocyte activation. Then we have got the YKL40, which is a chitinase 3 like protein 1, which is also a marker of astrocyte activation. And we can actually measure these in the CSF. Even now, we can very quite clearly, easily measure that. Now we've got the STREM2. It's a soluble triggering receptor expressed in myeloid cells too. The role of, we know that it is associated with a microglia. What we don't know whether it is associated with a pro-inflammatory or anti-inflammatory phenotype of microglia. There are several studies going on to understand how exactly whether we can use STREM2 as a marker of neuroinflammation. So apart from that, there are several other markers which have got the potential. Some of these markers are not easy to be measured in blood or CSF, but the newer techniques allows us to actually come up with a better measurement.
So still for research purposes, you would say for the most, and but would you say in the coming years there's a likelihood that a few of them may actually be available? Things like GFAP, for example. Again, nothing right now for clinical use, but
yes, I mean I think that as we have seen in the last couple of years with the amyloid and the tau, it is likely that the measurement of these markers or similar isoforms are likely to be transformed into the clinical practice to measure levels of brain inflammation. So yeah, the other markers definitely have got the role. Particularly the MAVO-B, I2BS, which is the imidazoline binding site, CSF1R, and P2Y12. These have been particularly targeted to develop novel PET tracers, so more than the fluid markers. There is potential for both being developed as a fluid marker and also some validation studies are ongoing for these PET tracers. We have to wait and see how this turns out to be.
So you've laid, Dr. Jensen, you've laid out this very sort of comprehensive sort of picture of the different parts of the neuroinflammatory system being disrupted or dysregulated in AD pathobiology. If we were to shift gears and think about therapeutics, what are some of the different approaches that are targeting some of these pathways in Alzheimer's disease? And could you make a few comments on those?
The way we have to approach inflammation, or particularly microglial activation, is that there is a pro-inflammatory and an anti-inflammatory phenotype of microglia. Even though the transcriptomic study has differentiated several other transcriptomic profile for the microglia. If you were to actually look at, and if you were to develop a treatment, we need to look at these microglia as they are either pro-inflammatory, or they are anti-inflammatory, or they are dysfunctional. The dysfunctional microglia, we're not able to do much with that. But for the what we need to do is to either promote the anti-inflammatory phenotype of microglia, or you actually suppress the pro-inflammatory phenotype of microglia. What is happening is that people are actually trying to suppress the pro-inflammatory phenotype of microglia and shift these pro-inflammatory microglia into anti-inflammatory microglia. To do that, which is a great opportunity, is actually to see what happens in real life by altering the morphology or the function of the microglia. And it is likely that along with other treatments, these newer agents will have an effect. There are several sort of antimicroglial agents being tested. One of them is this masitinib, which is a tyrosine kinase inhibitor. It actually reduces the neuroinflammation. It also reduces the reactive oxygen species. And by that, it then inhibits the glial activation and in turn reduces the neurodegenerative process. Now, one of the other ones is the NLRP3 inflammasome pathway. So there are several compounds which are particularly targeting NLRP3 inflammasome. And there is a great potential by modulating the NLRP3 pathway, we may be able to improve or reduce the inflammation and improve the neurodegenerative process. One of the other compound is the NE3107, which is an insulin sensitizing agent, and it has got influence on ERK and NF-kappa B pathway.
I know, Dr. Edison, I'm sorry, you are one of the world experts really also in the impact of the incretin signaling and GLP-1 receptor agonists. And can you tell us a little bit about your work and also some of the potential for that and how that's translated now into clinical trials?
The reason why I was first attracted to the GLP-1 analog is that identifying that the GLP-1 analogs can potentially reduce neuroinflammation, and it also improves the insulin resistance. So when I then looked at the action of GLP-1 analogs, it has got multiple actions. One, it actually reduces the inflammation in the animal models. It also reduces the amyloid protein in the animal models. It improves the synaptic function, and it also reduces the tau formation. And because of these multiple functions, I thought if you have got a disease, which is Alzheimer's disease, you've got multiple pathologies going on. That is the only way we could actually treat Alzheimer's disease. Now, if you were to look at it, not only it has got effect on amyloid tau and inflammation, it has got influence on synaptic function, it has got influence on mitochondrial function, as well as it improves the memory and overall, both in animal models. And our focus was to evaluate these mechanism of action in patients with Alzheimer's disease. With that in mind, we did about 204 patients with a daily injection of liraglutide and checking what happens to these people at the baseline and with the MRI, FDG PET, and various biomarkers, and then following them up over a period of 1 year. We're just about to report the results of the study, which is very encouraging. Now, if you actually come back to that, we are now specifically looking at what is the influence on inflammation and tau formation of Alzheimer's disease. And these patients are having the oral form of GLP-1 analog, oral semaglutide. And we are doing the amyloid PET to screen the patients. Then these patients are having tau as well as the inflammation PET and repeat scans over a period of time. Then we now have a study which is looking at the semaglutide in Alzheimer's disease, which is being conducted across the world. And they're looking at around 1,800 patients in 2 studies. So there's about 3,600 patients going through the study at the moment. We are anxiously waiting to see whether that actually will be a clinically important study demonstrating a clinical effectiveness in patients with Alzheimer's disease. So this is a very encouraging time to look at treatments apart from tau and amyloid. And if it were to be successful, the oral GLP-1 analogs are much easier to take rather than any of the injectables. And that will be transforming the field significantly.
Well, thank you very much, Dr. Edison. That was, I think, a good place to summarize our SMART goals, specific, measurable, attainable, relevant, and timely, which were to differentiate sort of the healthy actions of the neuroimmune system versus dysregulation resulting from chronic inflammation and other neurodegenerative conditions such as Alzheimer's disease, and also to think about the biomarkers and also identify potential therapeutic targets of neuroinflammation in Alzheimer's disease, particularly in the MCI and mild dementia stages. This CMEO stack is the second of a 3-part series. We hope that you'll take advantage of the other 2 stacks in the series, where we'll discuss also current emerging best practices for timely screening and detection and diagnosis of MCI and mild dementia and Alzheimer's disease, and also recent and emerging therapeutic options in AD. Thank you again, Dr. Edison, for sharing your knowledge with us and joining us today. And I want to thank the audience also for participating and for also being interested and engaged in providing the best care for our patients and their patients with Alzheimer's disease. Thank you again, Dr. Edison. Be well. Take care. Bye-bye now.
Thank you. Bye-bye.